Hello, Namaste students. Today we are discussing about one interesting central nervous system examination case, okay, which will be useful for both postgraduates and undergraduates, especially for postgraduate students. A 34-year-old female by name XX, okay, she is a teacher by occupation, Hindu by religion. She has studied till up to B.Ed and address she comes from Bangalore. This history was taken in the July 2019 when she presented to our hospital. So, retrospectively, the history will be presented when she presented to our hospital from July 2019. Swelling of both the lower eyelids since 3 weeks, pain in both the arms since 2 weeks, skin lesions since 2 weeks, pain in both the legs since 1 week. I repeat the chief complaints: swelling of both the lower eyelids since 3 weeks, pain in both the arms since 2 weeks, skin lesions since 2 weeks, pain of both the legs since 1 week. So, coming to the history of presenting complaint. This is a chief complaint. History of presenting complaint. Patient was apparently normal 3 weeks ago. Initially, she noticed swelling of both the lower eyelid. Started on the left side with redness. She noticed while she was getting up in the morning, followed by right lower eyelid swelling and redness. 1 day later, so first initially the left side of the lower eyelid swelling with redness. 1 day later, she developed the right lower eyelid swelling with redness. Swelling was sudden in onset, gradually progressive in nature. Swelling is not associated with any pain, blurring of vision, watering or double vision. So, there is just a swelling of the lower eyelid with the redness color, not associated with drooping of the eyelid. There is no ptosis, there is no drooping of the eyelid, no blurring of the vision, no redness of the eyes, inside the eyes, only the skin outside the lower eyelid is red color, and there is no double vision. History of pain. After that 1 week later, history of pain in both the arms, okay, she developed, which is dull aching and continuous the pain in both the arms. The left arm, initially it started the pain and then followed by the right arm within 2 days. She says the pain in both the arms is associated with swelling and weakness. The motor weakness, whatever she had, it was in the form of difficulty in combing the hair. She couldn't lift the hand above the head, difficulty in taking the head bath, history of difficulty in doing overhead activities. So, primarily she gave history of proximal muscle weakness. She couldn't lift the hand above the head, both the hands, both right arm and left arm, both the arms, right arm and left arm. So, there was a self activities were troublesome for her, but there was no distal muscle weakness. There was no history of difficulty in mixing the food. She could do that, buttoning and unbuttoning of her clothes. She could do that. The weakness, whatever she had, there was no diurnal variation. It was persisting throughout the day. This history is important because to rule out neuromuscular junction disorder, whether any diurnal variation is there. And this weakness was not associated with any exercise or any cold exposure. She noticed along with this pain and weakness of both the arms, skin lesions, hyperpigmented patches on the face she noticed, the two over the cheeks, followed 1 week later by hyperpigmented patches, erythematous, the reddish color patches on the hands and the toes, dorsum aspect of the hands and the toes. According to her, the skin lesions came suddenly and it is increased. All these history students was taken in July 2019 and from that date retrospectively I am telling her symptoms. The skin lesions were associated with itching, but they were not painful. And those skin lesions were not increased with photosensitivity on exposure to sunlight. Those skin lesions were not increased on exposure to sunlight. Then patient gives history of, after followed by that, patient gives history of pain in both the legs. Initially she had pain and weakness of both the upper arms. Then she developed pain in both the legs in the thigh region. And pain in both the legs was associated with weakness. This weakness and pain, it was sudden in onset and gradually progressive over 1 week. So, first 3 weeks back of July when she came to the hospital, July 11th, she had the swelling of the lower eyelid. After 1 week that she developed the pain and weakness of both the arms, then skin lesions. Then after 1 more week, she developed the pain in both the legs along with the weakness. It is a chronological order when she presented at that time. She tells the weakness in both the lower limbs is in the form of difficulty in getting up from the squatting position and difficulty in standing from the chair without the support. Without support, she couldn't stand up when sitting on a chair and she couldn't get up from a squatting position. So, symptoms suggestive of proximal muscle weakness. She says history of climbing, difficulty in climbing stairs up, again suggestive of proximal muscle weakness. There is no history of difficulty in holding the chappal. So, there was no symptom suggestive of distal muscle weakness. Chappal, she could hold it tightly. So, both upper limb and lower limb, proximal muscle weakness, fairly symmetrical. Upper limb and lower limb, symmetrical weakness of motor weakness. Distal muscle not involved both in upper limb and lower limb. Coming to some of the negative histories, there is no history of difficulty in moving from bed side to side. There is no truncal weakness. Side to side she can move around in the bed. No history of back pain or root pain. Just to rule out anything compressing her very young age, but still the history was asked. No history of Raynaud's phenomena. This history is important because she gives first the skin lesions and then the weakness. So, you have to think the muscle disease, the myositis, okay, the inflammatory myositis. One of the symptoms in inflammatory myositis is Raynaud's phenomena. That point you have to ask in the history, Raynaud's phenomena. Especially Raynaud's phenomena will be associated with one variety of inflammatory myositis that is known as anti-synthetase syndrome. No history of sensory symptoms. So, there is sensory symptoms are not at all there. Okay, she can appreciate the hot and cold water sensation. She can appreciate the cloth on her body. No history of bowel and bladder involvement. So, bowel and bladder is not involved. Just to rule out any spinal cord involvement is there. There is no bowel and bladder involvement. There is no sensory level or sensory symptoms. No history of fever. Fever or any preceding upper respiratory tract infection or any vaccination history is important because sudden onset like this acute onset and progressive weakness, okay. One of the DD, that to proximal weakness more, you have to think one of the important DD, anterior root involvement, multiple root, the demyelinating radiculopathy, that is AIDP, that is Guillain-Barré syndrome. So, to rule out that, you have to ask any history of fever, any preceding infections or any vaccination history. Here there is no history of that. No history of joint pains. Again, the inflammatory myositis will be associated with the arthritis. So, history of joint pain you have to ask. No history of photosensitivity, dry mouth or dry eyes. Photosensitivity, the skin lesion, whether it increases on exposure to sunlight, you have to ask. Dry mouth and dry eyes, because Sjogren's syndrome and other connective tissue disease can be associated with polymyositis and dermatomyositis, one of the inflammatory myositis. So, you have to ask that history, whether she has any associated connective tissue disease symptoms. There is no symptom suggestive of cough or breathlessness. This history is important because everything started with the skin lesion and the proximal weakness bilaterally with the pain of both the upper limb and lower limb, the muscle pain. So, they can be associated with other system involvement in the inflammatory myositis like cardiac involvement, so breathlessness, exertional breathlessness, palpitation you have to ask. And then respiratory, it can be associated with interstitial lung disease, bronchopneumonia or alveolitis. So, you have to ask any cough, respiratory symptoms and breathlessness. No history of weight loss or weight gain. So, this proximal muscle weakness, which will be insidiously progressive, can be associated with so many endocrinological diseases. Almost all the endocrinological diseases can produce proximal muscle weakness, bilateral symmetrical. So, you have to ask if there is a thyroid, any weight gain or weight loss history. Okay. The other endocrinological disease which can be associated with proximal muscle weakness, both upper and lower limbs, is Cushing's, Conn syndrome, acromegaly, hyper and hypothyroidism. All can be associated with the proximal muscle weakness. So, that is why the weight loss and weight gain history was asked, relevant to that. No history of loss of appetite or a weight loss history. This history is also very important because the inflammatory myopathy, some of the inflammatory myositis will be associated with occult malignancies. So, that is why any loss of weight or loss of appetite history you have to ask. No history of headache because the systemic features can be there, some of the inflammatory myopathy systemic features. Then symptoms suggestive of cranial involvement. She is not giving any history of cranial involvement symptoms. So, the loss of smell, any blurring of vision, fifth nerve symptoms like numbness of the face, difficulty in chewing, drooling of saliva, or any hearing loss, nasal regurgitation, difficulty in swallowing, hoarseness of voice, though those symptoms she is not giving the history. The inflammatory myopathies can be associated with dysphagia, dysarthria. Okay, that point you have to ask. So the cranial symptoms, any dysarthria, dysphagia is there or not, you have to ask. And why we are asking all these points in her in this history is because by the history only she gives pain in the muscle along with the symmetrical weakness with the skin lesion. Because we are suspecting inflammatory myositis, these relevant points are important in the history. So for these reasons, she was admitted to the hospital in the July 2019 on 11th. Then after immediately one day, next day only, she told she had palpitation and breathlessness, and she told she had developed severe pain. And she told pain was radiating to the left arm, shoulder and back, and for which she was evaluated there. Let us see what the evaluation came at the end of our discussion. This symptom, whatever she had, palpitation and breathlessness. As I told in the history, initially she didn't have palpitation and breathlessness. After developing the weakness of both the upper limb and lower limb when she was admitted to hospital, in the hospital she had. As I told, these inflammatory myositis can be associated with other symptoms, especially cardiac. They can have myocarditis. That is a probably she might have had a myocarditis with the palpitation and breathlessness is a possibility. Examination and investigation what she had for this symptom explanation at that time. Then coming to the past history, she is not a diabetic, hypertensive, epileptic or tuberculosis. There is no history of drug intake. This history is very important because so many drugs can act like a toxins and they can present with the proximal muscle weakness. So which are the drugs you will ask in the history, okay, especially to know whether they develop toxic myopathy or not. Almost all the cholesterol reducing agents like HMG co-reductase inhibitors, statins, fibric acids, niacin can produce myopathy, toxic myopathy. Glucocorticoids, especially 9-alpha fluorinated glucocorticoids like triamcinolone, dexamethasone, betamethasone can produce proximal muscle weakness. Non-depolarizing muscle relaxants, then autoimmune myopathies like because of statins, checkpoint inhibitors which you use in malignancies, and D-penicillamine. Then amphophilic drugs like amiodarone, chloroquine, hydroxychloroquine. Then microtubule inhibitors like colchicine. Then addictive drugs like alcohol, heroin, amphetamine can produce toxic myopathies and weakness like this, bilateral symmetrical. And antiretroviral drug, zidovudine. So these drugs you have to keep in mind and you have to ask the history of drug intake whenever they present with the bilateral symmetrical proximal muscle weakness. Family history is not significant, very important, especially suppose if her weakness would have been slowly over the years progressed, over 5 to 10 years, along with the family history. Then you would have thought of muscle dystrophies as the one of the differential diagnosis. Limb girdle involving the upper limb and lower limb with the family history. Slowly progressive over the years, then you would have thought of a limb girdle. Suppose if a 5-year, 10-year-old child presents with a family history, slowly onset bilateral symmetrical weakness like this, then you will think of a Duchenne's muscular dystrophy. So family history is important. In this inflammatory myositis, there won't be usually family history. Here also there is family history is not significant. Personal history, patient takes mixed diet, normal bowel and bladder habit, sleep is adequate, appetite is normal. She is married and has children. One is 10 years, another is 5 years of age. She attained menarche at 13 years, married at 23 years, cycles are regular, normal flow. Treatment history, she is on omnocotil, Visalon 5 mg, mycophenolate mofetil 500 mg, 2 morning and 2 in the night, HCQ, night 1 tablet, calcium and cholecalciferol. She says July when these treatment were started, after that, after 6 months of treatment, her symptoms improved. This is the treatment which will be given for inflammatory myopathies, which I will discuss after the examination. Okay, what are the drugs will be given, how they will be treated, but she has been treated with this. So coming to the summary, a 34-year-old female presented with 3 weeks of history of swelling of both the lower eyelid and then followed by weakness and pain symmetrically in both the upper limbs, followed by weakness and pain in both the lower limbs symmetrically, without sensory involvement, without bowel and bladder involvement, and weakness is gradually progressive. What are the differential diagnoses you can think? And with the skin lesion present in the knuckles according to her and in the toes. First is the anatomical localization, where you want to localize. Can it be spinal cord? There is no stiffness history, there is no bowel and bladder involvement to say it is spinal cord, and there is no sensory involvement, no sensory level. So it cannot be spinal cord. Can it be anti-ahon, MND? Can it be? The mode of onset is very acute, sudden in onset. She has pain, both the upper limb and lower limb there is a pain which rules out motor neuron disease. And skin lesion is there, which is not a feature of MND. Everything developed after the skin lesion. And MND comes slowly over the years, not like this within weeks and days. So anti-onset is also ruled out. Next, coming to the anterior root. Can it be anterior root problem, Guillain-Barré? Guillain-Barré, there is no preceding history of fever or respiratory tract infection which can precipitate it. Otherwise, there also it will be acute like this, bilateral symmetrical, and it ascends there. First lower limb, then upper limb. But she gives history of first upper limb and then lower limb. And she gives there is skin lesions. Skin lesions, and it is not ascending, which is a feature again as Guillain-Barré syndrome, root, anterior root. Can it be neuromuscular junction disorder like myasthenia gravis? What are the point against it? There is no diurnal variation. It will be relapsing and it will go and it can come with exercise and activity. The weakness will worsen and diurnal variation will be there. She never gives that history. It is present throughout the day and there is no ptosis. Only there is a lower eyelid edema with erythematous lesions according to her. There is no ptosis. And the skin lesions is also a feature again as myasthenia gravis. Now, can it be a after neuromuscular junction disorder? Next is the muscle disease. Then after muscle disease, I will come to detail muscle disease, what muscle disease she can be fit into the thing. Then the post muscle receptor, can it be channelopathy? Can it be hypokalemic periodic paralysis? Again, periodic paralysis will be relapsing and remitting with exercise, with high carbohydrate diet. Some other periodic paralysis will aggravate and will come. And skin lesion again is not a feature of periodic paralysis. Now coming to the muscle, which we are thinking probably she is fitting anatomically into the muscle, myopathy. That is the anatomical localization. We are localizing her to the muscle because of these things. This is the anatomical localization. In a muscle disease, how do you approach the differential diagnosis? First heading is intermittent or sustained weakness. If the patient is intermittent weakness, what are the differential diagnoses you will think? Myasthenia gravis. That too especially if associated with the extraocular muscle involvement, ptosis. Then periodic paralysis, hypokalemic, hyperkalemic periodic paralysis will be intermittent weakness. Then one variety of myotonia dystrophy, paramyotonia congenita, where the weakness will increase with cold and exercise. Then there are some rare metabolic diseases like glycolytic metabolic problems, where with the exercise, the lactic acid won't elevate. If lactic acid elevate with the forearm exercise, then you will think of fatty acid metabolic diseases, carnitine palmitoyl transferase deficiencies. Rare, those are rare metabolic diseases, intermittent weakness with the exercise. Only these you consider intermittent weakness. Myasthenia gravis, periodic paralysis, paramyotonia congenita, and rare metabolic diseases. Next, persistent weakness. Like this in our case, the weakness is persistent. If the weakness is persistent, how do you approach a myopathy? If like in our patient, if there is a weakness of symmetrical bilateral upper limb and lower limb like this, you will consider inflammatory myopathies like dermatomyositis, polymyositis. Then endocrinological diseases, all which I mentioned, hypothyroidism, hypoparathyroidism, Cushing's, Addison's, vitamin D deficiencies, all can present like symmetrical bilateral affection. Toxic, the drugs which I told, all the drugs can present like this symmetrical bilateral upper limb and lower limb weakness. and metabolic causes. Suppose if the muscle disease is associated with myotonia, the increased stiffness of the hand, what are the diseases you will consider? Myotonic dystrophy, congenital myotonic dystrophy, paramyotonia congenita, and hyperkalemic periodic paralysis will be associated with stiffness, the myotonia. Suppose then other important the muscle disease where they can have bilateral upper limb and lower limb proximal weaknesses, muscle dystrophies, especially Duchenne's, Becker's, limb girdle dystrophies. They will have bilateral symmetrical upper limb and lower limb affection, Duchenne's, Becker's, limb girdle dystrophies. But their families will be there. Onset is over the years, not like here, where within weeks to months. They are the very slow onset on families will be. Suppose if there is an affection of face, facial muscles involvement along with scapula and upper limb, then you will think of facioscapulohumeral dystrophy. Suppose if there is an involvement of the eyes, what are the muscle disease we will consider? Which are the muscle disease which will associate with the eye involvement? Ptosis, myotonic dystrophy, thyroid diseases, one variety oculopharyngeal muscular dystrophy, where they will have the pharynx will be involved and eye will be involved, oculopharyngeal muscular dystrophy, and mitochondrial myopathies, where they will have the eye involvement along with the muscle involvement. Suppose if there is an involvement of the face and if there is a myotonia of the hand, then you will consider a myotonic dystrophy. Suppose if the flexor muscles of the hand and quadriceps in the lower limb is affected, then you will consider inclusion body myositis. Flexor muscles of the upper limb and quadriceps in the lower limb, you will consider inclusion body myositis. Students, myopathies and muscle dystrophies, by and large, it is proximal muscle weakness. But there are some rare muscle diseases which can involve the distal muscles. Okay? For undergraduate, don't need to remember it, but for a postgraduate, myofibrillar myopathy and some rare congenital distal muscle weakness can be there. So, this is how you approach a persistent weakness, a muscle weakness. So, anatomically you localize in the muscle because of those are the reasons which I told. Because of those reasons, you will say muscle and myopathy. Which myopathy? Probably you are considering now because bilateral symmetrical upper and lower limb, acute to subacute onset with the skin lesion, you will consider inflammatory myositis. Probably because the skin lesions in the knuckles, in the foot and in the lower eyelid, the swelling and the erythematous rash, you want to consider it as a etiology is dermatomyositis. Very simple, students. It is a logical way to approach. Okay. First is you have to localize, anatomical localization, then muscle, then how you approach a muscle disease, intermittent weakness, persistent weakness. Intermittent only few causes are there, 2 or 3 causes. Persistent, how do you approach all the varieties I told. So, Harrison has given a nice flow diagram, you can go through again, okay, after listening to this history, again you can revise it 2 or 3 times, students. So, history only so important, students, here, nothing else is required. No biopsy, nothing, you can make a diagnosis, it is a dermatomyositis, it is inflammatory myopathy. Such is the strong power of the history in CNS. So, students, that is the history of the discussion. Now, let us go to the examination. On examination, patient is conscious and oriented. Blood pressure is 100/60 in supine position. Pulse rate is 64 beats per minute, regular, normal volume, normal vessel wall, and there is no vessel wall thickening. No radioradial, radiofemoral delay. She is afebrile. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. The malar rash is present on the cheek. I will just show that. So, students, you are thinking one of the differential diagnoses as inflammatory myopathy and dermatomyositis. What are the things you have to specifically look? Some patients, they may have erythematous facial rash. Actually, she is having it. Okay, it was more at that time when he presented July 2019. But now also still you can see here. You can make out here and here the malar rash is present. Okay. There is no heliotropic rash, okay. At that time, she had a lower eyelid edema. The diagram when she had a lower eyelid edema, I have given in the PPT, that will be given in the video. Just look at that video when she had that lower eyelid edema, students. Just see that PPT. So, there is no heliotropic rash here. Even in that diagram, there is a edema, but there is no heliotropic rash in the diagram which I have given in the video. No shawl sign or a V sign. Even at that time, she didn't add any shawl sign or a V sign. That is erythematous rashes on the anterior part of the chest is the V sign. The erythematous rash on the back of the body is known as the shawl sign. That is also not there. No mechanic hands. Hands, there is no mechanic hands. So students, there is no mechanic hands. You can see here no mechanic hands. Okay, mechanic hands is a feature of anti-synthetase syndrome. Anti-synthetase syndrome, mechanic hands. There are no subcutaneous calcification is seen. That is a feature of dermatomyositis, subcutaneous calcification. No purpura, no skin thickening, and she had a erythematous rashes over the knuckles of the hands, okay, and the foot. That diagram I have given again in the PPT. Just look at that when she presented us in 2015, when she had Gottran sign and Gottran papules. Both Gottran sign and Gottran papule diagram is there in the video. Just look at that. Gottran macules are the erythematous rashes which are present over the knuckles, elbow joint, knee and ankle. The elevated erythematous plaques are known as Gottran's papules. She had both Gottran sign and Gottran's papules. Just look at those diagrams, students. So, no lymphadenopathy and no hyperpigmented knuckles. So, here you can see right now she is improved because she is on mycophenol mofetil and steroids. Coming to the central nervous system examination, students, the higher mental function, she has scored around the mini mental status examination 30 out of 30, orientation 10, registration 3, attention and calculation 5, recall 3, language is 9. Inflammatory myositis doesn't affect the higher mental function, so it is absolutely normal here. Coming to the cranial nerves, the first cranial nerve is normal. Second cranial nerve, visual acuity 6/6, visual field is normal, fundus is normal. Pupillary reflex is normal, color vision is normal. Second nerve is normal. Third, 4, 6, extraocular movements is full. Pupillary reflex, pupil is normal in size and reactive to light. And there is no diplopia and there is no nystagmus. Just I want to look the extraocular movement, students, because there are some myopathies which will be associated with the ptosis, as I told, oculopharyngeal muscular dystrophy, myotonic dystrophy, mitochondrial myopathies. Just our extraocular movements I will check. So, extraocular movements is normal, there is no ptosis, pupillary reflex is also normal. Coming to the fifth nerve, the motor examination, the muscles of mastication, it is not affected. The sensory, ophthalmic, maxillary, mandibular, it is normal, and corneal and jaw jerk, it is present and it is normal. Seventh nerve examination is important because one of the myopathy is facioscapulohumeral. So, the motor examination of seventh nerve I will do quickly, just have a look at it. And bell nodi, frontal belly of occipito frontalis, and tight muchi ಬೇಕು. ಆರ್ಬಿಕಲ್ ಆಕ್ಯುಲೈ ಸಾಕು. ಅಲ್ಲಿ ತೋರಿಸಿ ಹೀಗೆ ಮಾಡಿ, ಓಕೆ. ಅಲ್ಲಿ ಬಾಯಲ್ಲಿ ಗಾಳಿ ಇಟ್ಕೋಬೇಕು, ಹಿಂಗೆ ಇಟ್ಕೋಬೇಕು ಎರಡು ಕಡೆ, ಇಟ್ಕೋಬೇಕು. ಬಕ್ಸಿನೇಟರ್ ಸಾಕು ಬಕ್ಸಿನೇಟರ್. ಓಕೆ. ಸೊ ಬಕ್ಸಿನೇಟರ್ I am not able to, I won't tell her to whistle it for orbicularis oris because she is female. So buccinator, orbicularis oris, orbicularis oculi, frontal belly of occipito frontalis. Facial nerve is normal in her. You have to examine because facioscapulohumeral dystrophy, facial muscles will be involved. 9th and 10th, position of the uvula is central, gag reflex is normal. Movement of the chin against the resistance, tugging of the shoulder against the resistance is normal. Tongue 12th nerve examination is normal. Some patients with inflammatory myositis, especially dermatomyositis, can present with dysphagia, okay, and dysarthria. So gag reflex examination is important in inflammatory myositis. Coming to the motor system examination. This is important, student, motor system examination in this case because you are suspecting a muscle disease. So you have to examine the muscle power. So let me examine first nutrition and tone and then I will go to the muscle power examination. Nutrition, the upper limb, right side and left side, arm 25, forearm 23 on right side, left side arm is 25, forearm is 23. Lower limb, the right side thigh is 45, leg is 31, left side the thigh is 46, leg is 30 centimeter. So there is no wasting. Coming to the tone both upper limb and lower limb there is no tone, there is no hypertonia, which you expect a normal tone in myopathies unless a very late stage. Coming to the power of the upper limb and lower limb. Shoulder abduction, initial 15 degree is done by supraspinatus, till 90, 110 degree is done by deltoid, after 110 degree is done by trapezius. Shoulder adduction is done by pectoralis major and latissimus dorsi. Now, shoulder flexion and extension. Shoulder flexion is done by pectoralis major, anterior fibers of the deltoid. Shoulder extension is done by posterior fibers of the deltoid and latissimus dorsi. So, that is normal. Now, how to examine for a latissimus dorsi? ಹಿಂತಿರ್ಕೊಳ್ಳಿ, ಕೈ ಹೀಗೆ ಇಟ್ಕೊಳ್ಳಿ, ನಾನು ಹೇಳಿದಾಗ ಹಿಂಗೆ ಒಳಗೆ ತರಬೇಕು. ನಾನು ಹೇಳಿದೆ ತಗೊಂಬನ್ನಿ, ಹಾಂ ಓಕೆ ಸಾಕು, ಹಾಗೆ ಇರಿ. ದಿಸ್ latissimus dorsi, ಐ ವಿಲ್ ಟೆಸ್ಟ್ ಹೌ ಟು ಲುಕ್ ಫಾರ್ rhomboides now only. ಕೈ ಹೀಗೆ ಇಟ್ಕೊಳ್ಳಿ, ನಾನು ಹೇಳಿದಾಗ ಕೈನ ಹಿಂದಕ್ಕೆ ತರಬೇಕು, ಹಿಂಗೆ ನಾನು ಹೇಳಿದಾಗ ತಗೊಂಬನ್ನಿ. rhomboides, ಹಾಂ ಸಾಕು. ವಾಟ್ ಇಸ್ ದ nerve supply to rhomboides? It is dorsal scapular nerve. What is the nerve supply to latissimus dorsi? Thoracodorsal nerve. What is the nerve supply to deltoid? Axillary nerve. What is the nerve supply to pectoralis major? It is medial and lateral anterior thoracic nerve. Then what is the nerve supply to infraspinatus and supraspinatus? It is suprascapular nerve. How to look for infraspinatus? Infraspinatus you look like this. Ask the patient to hold the hand like this. Ask him to externally rotate the like this. I'll do now. Amma kai hige itko. So this is infraspinatus, you have to feel the muscle here back. Infraspinatus, infraspinatus, you have to feel the muscle. The nerve supply is suprascapular nerve. Then pectoralis major you can examine by ask the patient to tightly hold on the hip. That is one method. Another method is you can ask the patient to approximate the hand like this, especially for the clavicular part, for the pectoralis major. Yeah, coming to the examination of the elbow joint. So elbow flexion, elbow extension. ನಾನು ಹೇಳಿದಾಗ ಕೈನ ಹೀಗೆ ಮಡಚ್ಕೊಳ್ಬೇಕು, ಮಡಚ್ಕೊಳ್ಳಿ. ಯಾ, ಕೈ ಸ್ಟ್ರೈಟ್ ಮಾಡಿ. ಓಕೆ. ಎಲ್ಬೋ ಫ್ಲೆಕ್ಷನ್ is done by the biceps and brachialis. Elbow extension is done by triceps. Biceps and brachialis, the nerve supplies musculocutaneous nerve. Triceps, it is radial nerve. Then the wrist flexion, wrist extension. Wrist flexion, okay. So students, how to examine for the wrist flexion? ಮಡ್ಚ್ಕೊಳ್ಳಿಮ್ಮ, wrist flexion, wrist extension, ಕೈ ಹೀಗೆ ಇಟ್ಕೊಳ್ಳಿ, ಇದನ್ನು ಹೀಗೆ ಮಾಡಬೇಕು. Wrist extension, you do like this. Okay, ಸಾಕ್ಬಿಡಿ. Okay, students, upper limb, the shoulder joint, elbow joint and wrist joint is normal. Let us examine the small muscles of the hand. Why I am discussing the small muscles of the hand in this myopathy, even though it involves proximal muscles, is some of the myopathies can have distal muscle weakness. That is why, and also it will be revision for you students, which are the nerves supply to the small muscles and how to examine. That is why I will be discussing small muscles of the hand here. Okay, right. Now first I will discuss the flexor pollicis longus. Flexor pollicis longus, you ask the patient to hold the hand like this and then flex like this. Then extension is done like this. Okay, if you apply the pressure here, extensor pollicis longus. If you apply the pressure here, extensor pollicis brevis. Flexion, extension. At right angle to that, adduction and abduction will occur. This is adduction, this is abduction. Okay, now I will show how to look for these muscles. ಕೈ ಇಟ್ಕೊಳ್ಳಿ ಅಮ್ಮ, ಇದೆಯಲ್ಲ ಹೀಗೆ ಮಡ್ಚ್ಕೋಬೇಕು. ನಾನು ಹೇಳಿದಾಗ ಮಡ್ಚ್ಕೊಳ್ಳಿ. ಫ್ಲೆಕ್ಸರ್ ಪಾಲಿಸಿಸ್ ಲಾಂಗಸ್, ಗುಡ್. ಮಡ್ಚ್ಕೊಳ್ಳಿ. ಫ್ಲೆಕ್ಸರ್ ಪಾಲಿಸಿಸ್ ಬ್ರಿವಿಸ್, ಈ ಬೆರಳನ್ನ ಸ್ಟ್ರೈಟ್ ಮಾಡಬೇಕು ನಾನು ಹೇಳಿದಾಗ ಮಾಡಿ. ಎಕ್ಸ್ಟೆನ್ಸರ್ ಪಾಲಿಸಿಸ್ ಲಾಂಗಸ್ ಸಪ್ಲೈಡ್ ಬೈ ರೇಡಿಯಲ್ ನರ್ವ್, ಸ್ಟ್ರೈಟ್ ಮಾಡಿ. ಎಕ್ಸ್ಟೆನ್ಸರ್ ಪಾಲಿಸಿಸ್ ಬ್ರಿವಿಸ್ ಸಪ್ಲೈಡ್ ಬೈ ರೇಡಿಯಲ್ ನರ್ವ್. ಫ್ಲೆಕ್ಸರ್ ಪಾಲಿಸಿಸ್ ಲಾಂಗಸ್ is supplied by median nerve. Flexor pollicis brevis, it has medial head and lateral head. Medial head is supplied by the ulnar, the lateral head is supplied by the median nerve. Flexor pollicis brevis. Okay. Now adduction and abduction. This is adduction, this is abduction. Abductor pollicis longus is examined by ask the patient to touch the pen above it. Abductor pollicis longus supplied again by radial nerve. For abductor pollicis brevis, you will put a pen here and ask the patient to touch your finger above. In finger touch ಮಾಡಿ ಅಮ್ಮ, finger touch ಮಾಡಿ. Abductor pollicis brevis supplied by median nerve. Abductor pollicis longus is supplied by radial nerve, whereas abductor pollicis brevis is supplied by median nerve. Okay. Then you have one more abduction. This is known as a radial abduction. This is radial abduction. Agla ಮಾಡಿ ಅಮ್ಮ, radial abduction. Whereas the abduction which she has done with this like this, in on belt touch ಮಾಡಿ ಅಮ್ಮ, this is palmar abduction. This is palmar abduction. This is radial abduction. This is radial adduction. ಈ ಬೆರಳನ್ನ ಹೀಗೆ ಮಾಡ್ಕೊಳ್ಳಿ ಅಮ್ಮ, yeah, radial adduction. And one more adduction is, you can do ulnar adduction. Tight ಆಗಿ ಇಟ್ಕೊಳ್ಳಿ, ulnar adduction. This is adductor pollicis. Adductor pollicis is supplied by ulnar nerve. Abductor pollicis longus is supplied by radial nerve. Abductor pollicis brevis is supplied by median nerve. Extensor pollicis longus is supplied by radial nerve. Extensor pollicis brevis is supplied by again radial nerve. Then opponens pollicis, ಹೀಗೆ ಇಟ್ಕೊಳ್ಳಿ ಅಮ್ಮ, opponens pollicis is supplied by median nerve. Then you have introgious, palmar introgious, dorsal introgious. Abduction, dab, dorsal introgious. Okay, abduction. Palmar introgious, adduction. Hold a paper, tight ಆಗಿ ಇಟ್ಕೊಳ್ಳಿ paper. Palmar introgious. Palmar introgious and dorsal introgious both are supplied by ulnar nerve. Then you have lumbricals. Lumbricals, flexion at the metacarpophalangeal joint, flexion at the metacarpophalangeal joint, extension at the interphalangeal joint. ಈ ಬೆರಳು ಇದೆಯಲ್ಲಮ್ಮ, ನಾನು ಹೇಳಿದಾಗ ಹೀಗೆ ಮಡ್ಚ್ಕೊಳ್ಬೇಕು, ಮಡ್ಚ್ಕೊಳ್ಳಿ, ಹಂಗಲ್ಲ, ನಾನು ಬೆರಳು ಇಟ್ಕೋಬಾರ್ದು, ನೀವು ಮಡ್ಚ್ಕೋಬೇಕಷ್ಟೇ, ಹೀಗೆ ಮಡ್ಚಿ, ಓಕೆ. ದೆನ್ ಎಕ್ಸ್ಟೆನ್ಷನ್ ಅಟ್ ದ ಇಂಟರ್ಫೆಲೆಂಜಿಯಲ್ ಜಾಯಿಂಟ್ಸ್. ಈ ಬೆರಳು ಇದೆಯಲ್ಲ, ಈಗಿರಲಿ, ನಾನು ಹೇಳಿದಾಗ ಹಿಂಗೆ ಮಾಡ್ಕೋಬೇಕು, ಹಿಂಗೆ ಮಾಡ್ಕೋಬೇಕು, ಮಾಡಿ ಇದು ಇಲ್ಲಿ ಮಡ್ಚಿರಬೇಕು, ಈಗ ಸ್ಟ್ರೈಟ್ ಮಾಡಿ ಹೀಗೆ ಮಾಡಬೇಕು, ನಾನು ಹೇಳಿದಾಗ ಮಾಡಿ. Extension at the interphalangeal joint, flexion at the metacarpophalangeal joint, extension at the interphalangeal joint, lumbricals. The first two lumbricals are supplied by median nerve, the third and fourth are supplied by the ulnar nerve. Then you have flexor digitorum profundus, flexor digitorum superficialis. How do you look for that? Profundus, the first two are supplied by the median nerve, the third and fourth are supplied by the ulnar nerve. Next, flexor digitorum superficialis. Flexor digitorum superficialis is supplied by median nerve. Okay, these are the muscles examination of the small muscles of the hand. Okay. It is though not relevant in this case. Why I discuss this? Because some of the myopathies can have distal muscle weakness, and it is a revision for you. The detailed examination of the small muscles I also discussed in CNS examination, students, in the general when I given the videos. That also you can go through again once more. It will be a revision for you. Small muscle examination of the hands will be asked especially for postgraduate students, and you should know how to examine the small muscles of the hand. Okay. Now, this is the upper limb. Let us come to the lower limb muscle power examination. So, lower limb muscle power examination, hip flexion, iliopsoas, hip extension, gluteus maximus. The nerve supply to psoas is nerve to psoas. The nerve supply to iliacus muscle is femoral nerve. The nerve supply to gluteus maximus is inferior gluteal nerve. Okay. Hip flexion, hip extension. Normal. Now, next coming to the abduction, adduction. Hip abduction done by gluteus medius and minimus tensor fascial lata, supplied by superior gluteal nerve. Hip adduction done by adductor magnus brevis group of muscles, supplied by obturator nerve. Okay, right. Knee extension, knee flexion. So, knee extension done by quadriceps femoris, supplied by femoral nerve. Knee flexion done by biceps femoris, semimembranosus, semitendinosus supplied by tibial nerve. Next, dorsiflexion, ankle flexion. Dorsiflexion done by tibialis anterior, supplied by deep peroneal nerve. Plantar flexion ನಾನು ಹೇಳಿದಾಗ ಕಾಲನ್ನ ಕೆಳಗೆ ತರಬೇಕು ತಗೊಂಬನ್ನಿ ಅಮ್ಮ. Plantar flexion done by gastrocnemius and soleus supplied by tibial nerve. Inversion, eversion. Inversion, tibialis posterior muscle, nerve supplies tibial nerve. Eversion ನಾನು ಹೇಳಿದಾಗ ಈ ಪಾರ್ಟ್ ಇದೆಯಲ್ಲ ಇದನ್ನು ಮೇಲ್ ಮಾಡಬೇಕು ಹಿಂಗೆ ಮಾಡಿ ಅಮ್ಮ. Eversion done by peroneus tertius supplied by deep peroneal nerve. Okay students, by and large in her the muscle power is normal both in upper limb and lower limb, but when she presented to us in July 2019 11th, at that time the power was right side shoulder girdle was 4/5, left side it was 3/5, hip muscles right side was 4/5 and left side it was 3/5. Because she is on treatment, dramatically responded to the steroids and mycotinol mofetil. She has improved the skin lesions also and the motor power examination also. And depending upon the muscle involvement, some of the muscle weakness will give a clue to some of the involvement. For example, if the patient is inability to close the eyes, then orbicular is oculi. Suppose if the patient is inability to lift the head with the supine position, flexor muscles of the neck. Inability to extend the neck on a prone position, extensors of the neck. Then inability to get up from a sitting position, hip proximal muscle weakness. Then waggling gait, hip muscles will be weak if there is a waggling gait. Suppose if the patient cannot walk without bending the knee, okay, if the patient cannot walk without hyperextending the knee, that is known as a knee buck knee, that is quadriceps weakness, okay. They have to hyperextend and then only they have to walk if there is a quadriceps weakness, that is knee buck knee. Then whether patient can walk with the heel. If the patient cannot walk with the heel, then dorsiflexors is the weak, the foot dorsiflexor. Then if the patient cannot walk with the toes touching the foot, okay, the toe walking, if it is not possible, because that action, whenever they touch the toes, it is a plantar flexion. So gastrocnemius and soleus should be normal. If that is weak, they cannot walk with the toes touching the foot. So some muscles will give clue to the some weakness, and if there is a goer sign, you ask the patient to sit on the floor, ask to get up, they cannot walk, they cannot stand up without taking the help of their own body, that is called as a goer sign, especially seen in Duchenne's and Becker's muscular dystrophies. Okay students, so these are some of the muscle weakness, will give some clue to the some of the which muscles are involved, some of the actions. So coordination, it is normal in her, there is no cerebral signs, okay, top to bottom coordination is normal in her. Coming to the reflexes, superficial reflexes, corneal, conjunctival, abdominal is normal, and plantar we have to see because it is very important reflex in any CNS examination. So let us examine the plantar inner. It is neither extensor nor flexor, coming mute. Here also, left side coming flexor, but right side it is mute. Okay. Okay. Anyway, we didn't expected any the cortical lesion or spinal cord. So plantar, as we expected, it is flexor on left side, right side it is coming mute only. No involuntary movement. Sensory system, the fine touch, the posterior column, the proprioception, fine touch is normal. Spinothalamic tract, the temperature, the pain, pinprick, it is normal. The gait is also normal, the skull and spine is normal. Autonomic nervous system is normal, and the other system, respiratory and CVS and per abdomen, now it is normal. Probably she had a myocarditis at that time in July 2019, and she was treated at that time for that. Okay. So now what are the positive findings she had when she came at 2019 July? She had edema of the lower eyelid, erythematous lesion in the lower eyelid and the face, and she had erythematous lesion on the knuckles and on the foot, along with the symmetrical weakness both the upper limb and lower limb. Okay, there was nothing to suggest spinal cord involvement. Plantar was flexor, tone was normal. Okay, and reflexes Deep tendon reflexes is very important. I'll elicit. I just forget deep tendon reflexes. Outer superficial reflexes. Chylidium. It is coming. Brachioradialis. Reflex is there. It is coming. Triceps present. You can make out student. This finding is important because one of the DD you consider was Guillain-Barré syndrome. The lively reflexes rules out Guillain-Barré syndrome. In the lower limb, I'll see the knee jerk. You can make out. It is present. Students, you can make out. ಖಾಲಿ ಹೀಗೆ ಮಾಡಿ. So, knee ankle is present. Okay, the reflexes, the presence rules out the Guillain-Barré syndrome. Okay, right. So then there are no other involuntary movement. Sensory system is normal. Pinprick, touch, vibration, joint position, everything is normal. Gait, skull and spine is normal. Autonomic nervous system is normal, and other system examination is normal. Okay, right. So what are the positive findings you got in her? So when she presented around in July 2019, she had the lower eyelid edema, and erythematous rash over the face and also over the knuckles and the dorsum of the foot. Along with that, the symmetrical weakness of both the upper limb and lower limb with the reflexes which is present. So we didn't think spinal cord because no tone is increased, plantar is flexor, it is not extensor. Okay, and anterior root Guillain-Barré unlikely because the reflexes are present. Then myasthenia gravis history wise only you can rule out because there is no diurnal variation. Periodic paralysis again you can rule out by history wise only, there is no relapsing and remitting there. It is not, usually it comes and goes with the precipitating factor like exercise, high carbohydrate intake. So she is fitting into the, and with the classic history of a muscle pain, symmetrical weakness and skin lesion, she is fitting into inflammatory myopathy. Okay, and that too dermatomyositis. Okay, students, she is a very nice case. You go through my PPT when she had that edema, the lesion of the Gottran papules, Gottran sign, go through that and then you listen to this discussion. Now, let me discuss a detail about the inflammatory myositis. When I used to do post graduation, at that time Harrison used to give only 3 types of inflammatory myositis, that is dermatomyositis, polymyositis and inclusion body myositis. But now the 20th edition Harrison has given 5 types. Okay, dermatomyositis, polymyositis, immune mediated necrotizing myopathy, anti-synthesis syndrome and then inclusion body myositis. These are the 5 types. There are some other types like infections associated like pyomyositis or eosinophilic myositis or granulomatous myositis. These are the other inflammatory myositis. Polymyositis, excluding the overlap syndrome, is very rare, whereas the dermatomyositis, immune mediated necrotizing myopathy, inclusion body myositis occur with the equal frequency. Inclusion body myositis occurs in more than 50 years of age group. Polymyositis occurs in adult age group, whereas dermatomyositis, immune mediated neuropathy, anti-synthesis syndrome occurs both in children and adults. Inclusion body myositis occurs in male patients. Immune mediated necrotizing myopathy occurs both in males and females, whereas dermatomyositis, polymyositis, anti-synthesis syndrome occurs predominantly in females. Whenever a patient comes with a weakness like this, of a motor weakness, it's our duty to localize where the problem is, whether it is in the cortex, in the spinal cord or in the antion cell, or in the root, or in neuromuscular junction, or in the muscle. For this, a proper history is important, the past medical history, any past drug intake history is there. Then the pattern of weakness, whether any winging of scapula is there, hypertrophy or atrophy of the muscles, or any contracture is there, rash, or any sensory abnormality. These points you have to ask in the history. If there is any fasciculation, that is a feature of motor neuron disease. If there is a relapsing and remitting weakness is there, that goes in favor of myasthenia gravis. If there is any sensory abnormalities, then your diagnosis will be in spinal cord or a sensory roots, in the root and spinal cord. If a patient has a winging of scapula, atrophy or hypertrophy and contracture before the weakness manifests, that too with a family history and without sensory involvement, usually the muscle dystrophy will be the etiology. If the patient has the Gottron patches along with the symmetrical weakness, dermatomyositis, okay, the rashes over the heliotropic rashes over the lower eyelid, the Gottron patches along with the weakness, symmetrical weakness, it is dermatomyositis. Whereas typically if the patient has the weakness of the flexors of the upper limb with the quarters of weakness in the lower limb, then that is inclusion body myositis. Suppose clinically if you are not able to make a diagnosis, what the problem is, where the weakness is, what is the etiology, then you have to do the laboratory investigations. Almost all the myopathies will have elevated creatinine CPK. Creatinine kinase will be elevated. That is a marker of a muscle necrosis. But there are some myopathies where creatinine kinase can be normal, but by and large, if the creatinine kinase is more than 2000 international units, then the myopathy is the usual cause. Then what are the other laboratory investigation you can do in muscle disease? There are some myositis specific antibodies like in dermatomyositis, melanocyte differentiating antigen 5, transcription intermediate factor 1, MI2, nuclear matrix protein 2. If it is there, then diagnosis is established. Let us see what has done to our patient after the end of the discussion. Suppose if the antibodies also not give any clue to the diagnosis, you can do EMG and nerve conduction study. EMG and nerve conduction study doesn't give the etiological diagnosis. It will just give where the problem is, which part of the muscle, and you can do a biopsy there. Only that much it will give a clue. The muscle MRI you can do. The muscle MRI will detect the fat deposition, atrophy or hypertrophy, and muscle edema. Biopsy you should not do in any patient without the creatinine kinase elevation, the objective clinical evidence of the weakness, or any abnormal EMG evidence. Then only you have to do a biopsy. All polymyositis patients you have to do a biopsy because to rule out inclusion body myositis. Biopsy is a must in immune mediated necrotizing myopathy because only on biopsy you can diagnose that. Whereas in dermatomyositis, like in our patient, if myositis specific antibody is positive along with the typical clinical feature, biopsy is not required. In our patient also we have not done the biopsy. Then there are other diseases. For example, if the patient has severe muscle pain, subjectively they may complain weakness, but on objective evidence there is no weakness, unlikely they are having myopathy, unlikely. In a polymyalgia rheumatica, there will be a rise DSR and CRP, and in fibromyalgia, the all laboratory investigations will be normal. So with this background, what else we have done to our patient, I will tell. They have done antibody to MI2 which is positive. That is very specific, okay, for dermatomyositis. CPKMB is 11,930, very highly elevated. That is on July 2019. Then after the treatment, after 1 month, it came to 4,261. Then when she had a chest pain in the hospital, in the Manipal hospital, there they had done a troponin I which was positive and CKMB was more than 80. But coronary angiogram revealed normal coronaries, so no ISD. Probably she had a myocarditis at that time. That is the reason for the elevation of CKMB. So because she had a typical skin features along with the weakness and antibody to MI2 positive, they were not done a biopsy, not required. And after starting the treatment, she dramatically responded to the immunosuppressants. Okay, right. So next coming to the individual inflammatory myopathies. Dermatomyositis. Dermatomyositis is present like this in our case with the symmetrical weakness of both the upper limb and lower limb. Along with that rash, they can have a heliotropic rash in the lower eyelid, which is erythematous, along with the edema, which our patient is having edema. I have shown the diagram, you can see that. They can have a erythematous patch, the Gottron's sign over the knuckles, elbows, knees and ankles. If it is raised, it is known as the Gottron's papules. The skin lesion may come along with the weakness or it may precede 1 or 2 months. In our patient, it came along with the weakness. Some patients may have only skin lesion without muscle weakness, that is known as amyopathic dermatomyositis. And some patients, they may have only muscle weakness without skin lesions. Both are possible. The skin lesion in dermatomyositis indicates the activity of the disease. Unlike the skin diseases in psoriasis, cutaneous lupus erythematosus, atopic dermatitis, the skin lesion in dermatomyositis will trouble their life. It will be intensely pruritic, like in our case, it is pruritic. The dermatomyositis patient, they can have associated symptoms like dysphagia, dysarthria, and other systems can be involved, lung and heart, carditis and interstitial lung disease. They can be breathless because of the ILD, bronchopneumonia or alveolitis. The lung disease manifestation will be associated with anti-synthetase antibodies. 20 to 15% will have associated malignancy dermatomyositis. So, you have to be especially careful, okay, for dermatomyositis to look for the malignancies. They can have subungual telangiectasias and subcutaneous calcification in general physical examination. Now, coming to the laboratory investigations. Laboratory investigations, the anti-myositis antibodies, there are some anti-myositis antibodies which are very specific to the dermatomyositis. MDA5, melanocyte differentiating antigen 5, TIF1, transcription intermediate factor 1, MI2, nuclear transcription protein 2, nuclear matrix protein 2, that is NXP2. Each antibody has a specific clinical manifestation. If MI2 is there, it is benign usually, like our patient. She dramatically responded and she will respond nicely. MI2. If MDA5 is there, melanocyte differentiating antigen 5, usually they will have a skin manifestation without the muscle involvement. They can have the rashes with the cutaneous ulcers and interstitial lung disease can be there. Whereas transcription intermediate factor 1 and nuclear matrix protein 2, if it is there, they will have associated malignancies. You can do EMG, that will be a non-specific finding, and MRI of the muscle you can do, that is also will show the edema or else it will be very non-specific findings. Then histopathology. Suppose if you don't have a diagnosis even after the antibody test, then you have to go for histopathology. They will have a perivascular atrophy. Perivascular atrophy is in 50% of the patients. They will have perimysial degeneration. The inflammatory cells, B cells, macrophages will go and attach to the MSC1 complex sarcolemmas, and membrane attack complex will be there in these sarcolemma of the muscle fibers. Immunohistochemistry will show the myxovirus resistant protein staining, which is very specific and sensitive for dermatomyositis. Then coming to the associated malignancy, I told 10 to 50% will be associated with the malignancies. Coming to the treatment, they respond to steroids. They respond to steroids, okay. As I told, the MI2 variety has a good prognosis. They respond dramatically to steroids like in our patient. Next is polymyositis. Polymyositis will present with weeks to months the onset duration, the duration and action. The onset will be in the weeks to months, the weakness. That is also symmetrical, bilateral upper limb and lower limb weakness, motor weakness. That also will be associated with the other systems like heart, lung. Then coming to the laboratory investigations. The EMG will be non-specific in polymyositis. The MRI will show the muscle edema. In polymyositis, rectus femoris will be affected most compared to the vastus medialis and lateralis in inclusion body myositis. That is the difference between inclusion body myositis and polymyositis. In polymyositis, rectus femoris will be affected most, vastus medialis and lateralis in inclusion body myositis. Coming to the histopathology, there will be a perimysial, endomysial and capillary infiltration by the inflammatory cells, the macrophages and B cells, especially along the MSC1 complex of the sarcolemmas. Polymyositis and dermatomyositis can be associated with a connective tissue disease like mixed connective tissue disease, scleroderma, SLE, Sjogren's syndrome, and these are called overlap syndromes if they are associated with the connective tissue diseases. Overlap syndromes also respond nicely like the without overlap syndrome patients of polymyositis and dermatomyositis. The bad prognosis in both dermatomyositis and polymyositis is indicated by elderly age, the increase of the age group, associated other involvement like carditis, interstitial lung disease, then involvement of the cancers, then delay in the starting of the treatment or inadequate treatment. These are the things which indicates bad prognosis in both dermatomyositis and polymyositis. Polymyositis also responds to steroids, may not be very much like dermatomyositis, but still it responds to steroids. And polymyositis also will be associated with underlying malignancies in 5 to 10% of the cases, but most in dermatomyositis. Next is immune mediated necrotizing myopathy. Immune mediated necrotizing myopathy can be associated with underlying malignancy or idiopathic or connective tissue diseases like mixed connective tissue disease and scleroderma. Usually they have two antibodies. One is HMG-CoA reductase, antibody to HMG-CoA reductase. Another is anti-SRP, signal reduction protein, signal reduction particle. Anti-SRP and anti-HMG-CoA reductase. Anti-HMG-CoA reductase antibodies are present in the patient who take the statins. In some of the patients, this immune-mediated necrotizing myopathy can occur without the statin use, especially in children. Then you may confuse them for a limb-girdle dystrophy. The toxin-induced myopathy, usually if you stop the drug statins, the myopathy will improve. Whereas here, in immune-mediated necrotizing myopathy, even if you stop the statin, the weakness will keep on progress. That is the difference. So, in the laboratory investigations, EMG will be non-specific. You will find these two antibodies, anti-HMG-CoA reductase inhibitor antibody and anti-SRP antibody, signal reduction particle antibody. Then coming to the histopathology, it behaves like polymyositis. There will be endometrial inflammation with the inflammatory cell B cells, macrophages will go and occupy the sarcolemma which express MSC1. There will be muscle necrosis and regeneration. Immune mediated necrotizing myopathy is usually very difficult to respond to treatment with the steroids or immunosuppressants, and here CKMB will be elevated. The creatine kinase will be elevated. For immune mediated necrotizing myopathy, the treatment is IV immunoglobulins. They respond to that. You have to give steroids along with that one second line agent, then you have to try with the IV immunoglobulins. Next is antisynthetase syndrome. Antisynthetase syndrome, they have myositis like proximal muscle weakness of both upper and lower limb. Associated with that, they have non-erosive arthritis. This muscle pain arthritis is a feature of even dermatomyositis and polymyositis. Even they can have muscle pain and arthritis. Raynaud's phenomena is a feature of antisynthetase syndrome and mechanics hands. And even they can have erythematous rash in antisynthetase syndrome. Coming to the laboratory investigation, they will have amino acid RNA synthetase antibody. 25 to 30% of the patients will have amino acid tRNA synthetase antibody. It is known as anti-Jo antibody. Some of the types, the most common type of amino acid tRNA synthetase antibody is anti-Jo antibody. Antisynthetase syndrome, unlike the dermatomyositis and polymyositis, not associated with malignancy. The MRI will show the muscle edema. Then they will have interstitial lung diseases, most common. So, pulmonary function test will show diffusion capacity will be reduced and FEV1 will be reduced. CT scan will show honeycombing appearance of the lung. Coming to the histopathology, it behaves like dermatomyositis. There will be a perivascular atrophy. In dermatomyositis, there will be the muscle necrosis. Muscle necrosis is a feature of antisynthetase syndrome, whereas the muscle atrophy is a feature of dermatomyositis. The perivascular atrophy is a feature of dermatomyositis, whereas perivascular necrosis is the feature of antisynthetase syndrome. In dermatomyositis, I want to tell one more thing about the skin histopathology. There will be a cell poor interface dermatitis will be there in dermatomyositis. Like perivascular atrophy, how it happens, the basal keratinocyte cell will undergo damage in the skin. And between dermis and epidermis, there will be inflammatory cells will be there. The B cells, macrophages, inflammatory cells will be there between dermis and epidermis. Antisynthetase syndrome histopathology resembles like a dermatomyositis. The treatment is same, they respond to steroids, antisynthetase syndrome and immunosuppressants. Next is inclusion body myositis. It occurs in more than 50 years of age groups. As I told, it is not bilaterally symmetrical, it is asymmetrical. All the other myopathies are bilaterally symmetrical proximal, but this has a peculiar feature, inclusion body myositis. Upper limb flexor muscles of the hand will be affected, flexor digitorum profundus. Lower limb quadriceps will be affected. And as I told, quadriceps here, unlike polymyositis, vastus medialis and lateralis, whereas in polymyositis, rectus femoris. Slowly progressive inclusion body myositis, it won't respond to steroids unlike the other myopathies. They will have bedridden or they will use a wheelchair or a scooter by 15 years once they develop the disease. They won't respond to the immunosuppressants. Male patients, and they won't have associated increase of malignancy risk, inclusion body myositis. Coming to the laboratory investigation, creatine kinase also won't be elevated unlike the other myopathies in inclusion body myositis. If at all elevated, maybe very mild elevation of the CK, not a very high elevation of the CK in inclusion body myositis. There are cytosolic 5-nucleotidase antibodies in 1/3 to 2/3 of the patients. In a flow cytometry, we will show large granular lymphocytes and CD8 T lymphocytes will be elevated. Then you can do EMG, which is non-specific. Then muscle MRI you can do. Then coming to the histopathology. Histopathology will show rimmed vacuoles in the muscles. Along with that, cytochrome oxidase negative staining. The endoplasmic reticulum will undergo stress and autophagy, producing the protein particles like P62 and LC3. Like these endoplasmic reticulum stress and autophagy is also disturbed in primary biliary cirrhosis, inflammatory bowel disease and ankylosing spondylitis. Those diseases are also where there is endoplasmic reticulum stress and autophagy. They also won't respond to steroids like inclusion body myositis. Coming to the treatment, it is just a physical rehabilitation. By 15 years, they will become wheelchair bound and they will use their scooters for their movement, inclusion body myositis. And as I told before, there is no associated malignancy associated with the inclusion body myositis. Coming to the treatment of inflammatory myopathies, they respond to steroids, unlike only one is inclusion body myositis which does not respond to steroids. Steroid is the first line of management. You will start second line only in certain conditions. Which are those? If patient has a very severe weakness or associated other systems like carditis, interstitial lung disease, or if there is any adverse effect with the corticosteroids, or in immune mediated necrotizing myopathy, or very difficult to treat myositis, you will start a second line, or else steroids is the drug of choice. Once when you start a steroids, in whom you will start the second line? If you are not able to taper the dose of steroids, or if they don't respond after 2 to 4 months of treatment, in them you will start the second line of management. Immune mediated necrotizing myopathies you have to start along with steroid second line, then IV immunoglobulins. If not responded, rituximab should be added. And again I am repeating, IBM, inclusion body myositis, steroids they won't respond to that. Corticosteroids, you start with 0.75 mg to 1.5 grams per kg body weight. You can give maximum 100 mg per day. Usual dose all give 60 mg per day. You give for 2 to 4 months, then you start tapering 5 mg every 2 to 4 weeks till you reduce it to 20 mg either every day or alternate day. Then from there again you will start reducing 2.5 mg every 2 to 4 weeks till you make it 10 mg per day. That is a maintenance dose which she is having now, 10 mg per day. If the patient presents acutely with the weakness or involvement of the carditis or interstitial lung disease, initially 3 days you can give methylprednisolone 1 gram, then you can start the oral corticosteroid. While on steroids monitoring therapy, you should do creatine kinase, but to change the dose of the steroids, you should not use either the creatine kinase or the patient's subjective weakness. Only your clinical improvement and objective weakness, then only you have to change the dose of the steroids. While in steroids, they can worsen because of two things, either steroid myopathy or the treatment may be inadequate. How to distinguish these two? If the patient has a Cushingite feature, if the creatine kinase is normal, EMG is normal, and when you are increasing the dose of steroids, at that time, if the patient has a weakness, it is corticosteroid induced weakness. If creatine kinase is elevating and if the weakness develops while you are tapering the steroid dose, and if EMG shows abnormality, then that is due to the muscle disease because of the myopathy. Because the myositis, the weakness is there. That is how you distinguish. The second line of drug immunosuppressants here is methotrexate. You start with 7.5 milligram per week dosage, you will increase to 25 milligram per week. You maintain 25 milligram per week for 1 month. Then if it does not respond to that dose, you will add weekly subcutaneous injection. You can increase to till 35 milligram per week the subcutaneous injection. There are some adverse effects of methotrexate which you should be careful. Stomatitis, teratogenic drug it is. It can produce oncogenicity, cancers, ILD, renal and liver toxics. So, you have to always replace with the folinic acid. Cyclosporine 50 milligram per day. You can increase the dose 50 milligram every 2 to 4 weeks till you can give 3 milligram per kg body weight. It takes long time to act, cyclosporine, 6 to 18 months. 12% will develop systemic features like nausea, vomiting and fever where you have to stop the drug. And some patients will have TPMT deficiency, thiopurine methyl transferase deficiency. In them it produces bone marrow toxicity, thiopurine methyl transferase deficiency. Those who are having that, you should not give cyclosporine. Sorry, you should not give azathioprine. Next is a mycophenol mofetil. The dose is you can give around 1 gram per day. You can increase to 3 grams per day. It is a safe drug. Usually does not produce renal or any liver toxicity. That is why they have put on her the mycophenol mofetil in her. If there is a renal failure, you have to reduce the dose. IV immunoglobulins. Next, it is a drug of choice in immune-mediated necrotic myopathies. IV immunoglobulins. You will give 2 grams per day. The total dose is 2 grams over 3 to 5 days you can give. Once the patient start responding, you can either decrease the dose or the interval you can increase it. So, you can give 2 grams every once in 2 months or 1 gram every month. And as I told, that is a drug IV immunoglobulin where you will give for immune-mediated necrotic myopathy. Rituximab 1 gram you can give, after 2 weeks 1 gram IV infusion you can give. Then repeat the dose after 6 to 18 months. Then coming to the geographical distribution of the inflammatory myopathies. In Japan, 23% of the inclusion body myositis will have hepatitis C. In a developing country like India, you have to consider pyomyositis because of the bacteria and other infections and parasitic infections producing myositis. In HIV patients, usually produces inclusion body myositis and polymyositis. And as I told, dermatomyositis, polymyositis and immune mediated necrotic myopathy will be associated with underlying malignancy, especially nasopharyngeal carcinomas. So, you have to search for that nasopharyngeal carcinomas. So, which are the immunosuppressants you will give? Steroids, methotrexate, azathioprine, mycophenol mofetil, rituximab, IV immunoglobulins. Azathioprine, as I told, 50 milligram, then you can increase every 2 to 4 weeks till 2 to 3 milligram per kg body weight you can give azathioprine. And TPMT deficiency patient, you should not give it azathioprine. So, this is about inflammatory myopathies. So, as a postgraduate students, when they come with weakness, your aim is rather than knowing detail about all the inflammatory myopathies which may not be expected of you by a PG or a UG level, you should know how to approach it. We have to localize the anatomy. Why the weakness is due to, whether cortex, spinal cord, anterior, root or muscle. Then eliciting the signs. Then giving a differential diagnosis, approaching. That will be more expected of you rather than knowing finer aspect of inflammatory myopathies. But for a completion sake, I told little detail about the inflammatory myopathies. I given a PPT of the patient, same patient when she visited our hospital. Please go through those diagrams. It's a very interesting fine case which you will remember for long.